The etiology of diabetic foot, of course, we mentioned in brief previous presentation. Number one, diabetic peripheral neuropathy. Diabetic peripheral neuropathy is very famous to be a cause of diabetic foot. The blood supply will be affected at the level of the microvascular supply, which is called the microangiopathy or microvascular disease. In addition to lack of sensation, which is called neuropathy, both of them will lead to the syndrome of diabetic foot. Loss of sensation, of course, we have capillary damage due to diabetes and the loss of sensation of extremity and the injury due to loss of sensation, and then infection will be very high, okay, and then gangrene will ensue. The span between infection, simple and superficial cellulitis to chronic osteomyelitis, it can be very fast, can be very slow. We have to observe the patient. The diabetic foot syndrome is an interaction between the neuropathy, vasculopathy, and the microvascular disease, and the infection, and the bacteria, and the immune response of the patient, okay, and the diabetic control, and if he's smoking, all these will lead to the syndrome of diabetic foot. It is very frequent in our practice, and it should be properly management. It is curable. It can be, we can save the patient from amputation, but it has to be through a proper approach. One of our main enemies in the diabetic foot is the bacteria. Usually the bacteria are virulent and the patient is immunocompromised, so the battle is not fair. The microbiological feature of diabetic foot, it is various, it is variable. If we have superficial skin infection like cellulitis, okay, it is like same in any other healthy non-diabetic patient. It's streptococci or staphylococcus aureus. Group B streptococci can cause cellulitis, skin and soft tissue infection, and the chronic osteomyelitis. Such infection can cause bacteremia and fever and shivering, so we have to take care. We have also deep soft tissue infection, and this is more serious. And it is causing gas, some of them having gas-producing organism or gram-negative bacilli. It is appearing as necrotizing fasciitis and the compartment syndrome or myositis. Compartment syndrome, if you don't know it, it is simple. It is closed compartment with increased pressure. And it is very serious because once we have increased pressure, there is impairment of the blood supply and definitely gangrene will happen. We can lose the toe, we can lose the whole limb. Gas gangrene is not common because some doctors are saying he's having gas gangrene. It is not common in diabetic patients. In chronic osteomyelitis, the pathogens having group A and the group B streptococci, arabic gram-negative bacilli, and Bacteroides fragilis. Bacteroides fragilis, Escherichia coli, Proteus mirabilis, and Klebsiella pneumonia. Although Pseudomonas, we are meeting it frequently, but it is waterborne superficial also. Maybe contaminated by bacteria in wet socks and or dress, because especially the diabetic patients having high output discharge. When anaerobic infection occurs, it usually in a patient who is having ischemic limb or wound with necrotic tissue. That's why we have to get rid of the necrotic tissue as soon as possible. We have to correct ischemia as soon as we can. Clinician should bear in mind that severely infected, previously treated, or neglected diabetic wound can harbor virtually any species of bacteria. Recently, we have met, all of you I think heard about the multi-drug resistant organisms, which are like a nightmare for any surgeon because it is very difficult to control. Most important or most famous is MRSA, and this usually is the predisposing factor is long-standing wound which is not cured. or previous hospitalization and the chronic kidney disease. We need to, when we deal with diabetic foot, we have to take sample. So famous swab by the cotton, it is widely used, and until now it is widely used. The studies showed that tissue culture is much better. That's why it is better to take a specimen from the tissue, deep tissues, while you are doing the culture, so that you can have a proper sampling and the proper identification of the organism. But we, until now, we are using in routine clinical use, at least to have an idea about the organism. We have cellulitis. Cellulitis is usually met by the general practitioner in the general practice, and it is the easiest diabetic foot infection to cure. You should manage it. As soon as you see, you should manage it. It doesn't have the same circulatory limitation because usually it will not cause edema, that degree of edema, and it will not cause spread of infection in deep structure or compartment syndrome. So it is easier for medication to reach the infection site as it is superficial. But deep and soft tissue, deep skin and soft tissue infection, usually curable, but they can be life-threatening and result in substantial long-term morbidity. Of course, chronic osteomyelitis is the most difficult, and diabetic foot infection to cure requires surgical debridement before antibiotic therapy can be effective. So now we should not antibiotic alone, because I notice in my practice that many doctors are relying on antibiotic only. And this is the medical point of view still. They are saying that it requires surgical debridement. We say it must need surgical debridement. Glycemic control, you must control diabetes. If you not control diabetes, you are not trying to manage the infection. International Working Group of Diabetes gave some recommendation for diabetic foot infection control. We should use this agent, which efficacy is demonstrated. To start with them, penicillins, cephalosporin, carbapenem, and the selection of the antibiotic will consider the most likely cause of organism I am going to kill, to fight, and the history and severity, and there is published evidence of the agent I'm going to use in this case, and is there is risk damage to the commensal flora, and is there is drug interaction with the medicine he's using, and is the medicine I am going to use available, and its cost, because we meet in the culture result, they are putting some medicine which is not available in Bahrain at all. So what I cannot use. You should put something which I can prescribe to the patient and the patient can buy. The patient and with skin or soft tissue diabetic foot infection should undergo at least 1 to 2 weeks of antibiotic therapy. And of course, our guide is the response of the infection to management. When no other indication for surgery exists. This is the point of view of internist, of course. Consider managing a patient with diabetes and uncomplicated for foot osteomyelitis via antibiotic therapy with no bone resection. We should evaluate, if necessary, with regard the need to surgery as well as intensive post-operative medical and surgical follow-up when probable diabetic foot osteomyelitis exists with concomitant soft tissue infection. So if patient with diabetic foot osteomyelitis should undergo antibiotic therapy for no more than 6 weeks, failure to see clinical improvement of infection within first 2 to 4 weeks should prompt the reconsideration of bone specimen collection, surgical resection, or selection of an alternative antibiotic regimen. So they will try, from their point of view, the antibiotic treatment for 6 weeks, but we should in the first 2 to 4 weeks to observe is there is improvement or no improvement. If no improvement, we have to revise our plan, either changing the antibiotic or resort to surgical intervention. So Mild infection, oral antibiotics that cover skin flora include streptococci, staphylococci, such as cephalexin, dicloxacillin, amoxicillin, clavulanate, or clindamycin are the effective choices. If MRSA infection is suspected, clindamycin, trimethoprim, sulfamethoxazole, or minocycline or linezolide may be used. If we have gram-negative aerobes or anaerobes, and we suspect it's dual drug treatment, like trimethoprim and augmentin or clindamycin, in addition to fluoroquinolone, levofloxacin, and or moxifloxacin. If you have moderate to severe infection, patient should be hospitalized for parenteral antibiotic therapy because you have to control the infection. Empiric choices should cover streptococci, MRSA, aerobic gram-negative bacilli, and anaerobes. MRSA is covered by vancomycin, linezolide, or daptomycin. Gram-negative aerobic organisms and anaerobic, we can use ampicillin, sulbactam, piperacillin, tazobactam, meronym, or ertapenem. Alternatively, we can use ceftriaxone, cefepime, levofloxacin, moxifloxacin, aztreonam, plus metronidazole. Should be sufficient to cover aerobic, negative, and anaerobic organisms. In some cases, we can, the decision of admission of the patient is depending on the severity of the case and depending on the socio-financial condition of the patient, because private admission in private hospitals is different from government hospital. If I am in government facility, I should admit immediately. But if I am in private facility, if I have a choice of using an injection, which is once daily, or the patient can come to take injection twice a daily as outpatient, so I can save him the cost of admission. Because you have to keep in your mind how much the patient will pay in total. It is long and costly disease, long time consuming and costly disease. For if you are going to be treated for 3 to 4, 6 months, then you have to calculate the cost so that the patient can afford as much as he can. But the decision is depending upon the severity. You cannot choose the cost on the expense of the health. If the patient cannot afford the private, then he should be admitted to government hospital. Vascular management, infection management, and the prevention and the pressure relief, which is called offloading. The foot is having a special situation because we are putting all our weight over the foot. And if the wound in the foot, then this weight will affect the healing and will squeeze the discharge and secretions and pass to spread through the planes of the tissue planes to the leg. So, and also will delay the healing of any ulcer. So offloading is a gold standard in managing diabetic foot. Total contact casting is a preferred method for offloading plantar diabetic foot ulcer because it has the most consistent demonstrated the best healing outcome and is cost-effective treatment. Of course, the problem that the patient is not adherent. Usually doesn't like the shoe. As you see, it is long and heavy, and all of them, because of neuropathy, they have weak muscles, so they hate this shoe. So they are not wearing it. Most of them, they are wearing it while coming to the clinic only. We can see this video.
Watch diabetes videos at clearlyhealth.com. As a person with diabetes, it is important for you to care for your feet properly every day. If you have nerve damage, known as neuropathy, you may not feel pain if you injure your feet. Because of this, an infection can develop without warning. Decreased blood circulation slows healing. This can result in foot ulcers, which can eventually lead to amputation of the feet or legs. Prevent foot injuries by wearing shoes that fit well and have good support. Don't walk barefoot. Check your shoes before putting them on for small pebbles, worn areas. Avoid sandals.
Whatever you want, you can. If you're going to eat. And you cannot throw it, okay? After some time, it's not.
Socks are better if they do not have seams or mended areas. It is important to check your feet every evening for cuts, sores, red spots, swelling, or infected toenails. If you have any of these problems and they do not heal within 24 hours, it is important to contact your healthcare provider. If you have trouble seeing the bottom of your feet, try using a mirror. Before bathing or showering, test the water to make sure it is not too hot by using a thermometer or your elbow. If you use a thermometer, between 90 and 95 degrees Fahrenheit or between 32 and 35 degrees Celsius is safe. Water that is too hot can damage the skin. Do not soak your feet, as they can become dry and cracked, causing infection. Be sure to dry your feet well, using a patting rather than a rubbing motion. Be careful to dry between your toes and use talcum powder or cornstarch to keep the skin between your toes dry. Apply lotion to the top and bottom of your feet to keep them soft. Do not apply lotion between the toes, as this can cause the area to become too moist. Thick or hardened skin on the toes and bottom of the feet, called corns or calluses, can appear from skin rubbing against bony areas of the foot. If you have corns or calluses, it is important to talk with your doctor about how to remove them. Do not use corn plasters, corn and callus removers, or blades, as these may lead to infections. Trim your toenails straight across once a week. Smooth sharp edges with an emery board or nail file. Contact your doctor if they become thick or yellowed, or begin to curve and grow into the skin. Avoid using heating pads, hot water bottles, or campfires to warm your feet, and to carefully check your feet during cold temperatures for frostbite. Keeping your blood glucose levels in your target range through healthy eating and daily exercise can prevent or decrease nerve damage caused by diabetes. Daily foot care, comfortable shoes, and having your healthcare provider examine your feet at least once a year can help minimize serious long-term damage caused by diabetic neuropathy. For our full library of healthcare videos, go to clearlyhealth.com. Watch.
Okay, well, now we finish this presentation. Thank you very much.